We are live now. Good evening, everyone, and welcome to the Expert webinar. I take this opportunity to welcome you all on the behalf of Juventus Gromax. I am Harshada Chavan, and our state head of Kolkata, Mr. Supratik, is here with us. It is known that exocrine pancreatic insufficiency and diabetes may coexist, and despite its high prevalence, little is known about the clinical consequences and its management. So, our today's topic is challenges in the management of coexisting EPI and diabetes. I take pleasure to introduce our eminent speaker, Dr. Kaushik Chatterjee, to address this topic. Dr. Kaushik Chatterjee is a renowned gastroenterologist practicing for last 13 years. He pursued his DM in medical gastroenterology from the prestigious Institute of Christian Medical College, Vellore. He honed his skills in therapeutic endoscopy intervention and obtained a post-DM fellowship in advanced gastrointestinal endoscopy from the same institute. He is proficient in therapeutic ERCP, endoscopic ultrasound, and EUS guided interventions. He has thousands of diagnostic and therapeutic endoscopic interventions to his credit. Along with the endoscopic interventions, he has keen interest in the management of complex hepatological ailments, chronic pancreatitis, and inflammatory bowel diseases. So I request to all viewers for any queries, kindly type the content in chat box and after the session, the queries will be answered by Dr. Kaushik Chatterjee. So over to you, sir. I'll start the
Yeah.
presentation now. Yes, sir.
Hi.
Presentation is
Hi.
started.
Good evening. Good evening, everyone. So today's topic is diabetes and exocrine pancreas. Here we will initially briefly try to understand the relationship between diabetes and exocrine pancreas. That is how diabetes can affect the exocrine pancreas and how exocrine pancreatic diseases can lead to diabetes. Subsequently, we will try to understand their management and specifically the role of pancreatic enzyme replacement therapy in these particular situations. Next slide. So the discussion is divided into these subheadings. Next slide. Next slide. Yeah, if you look at the prevalence of diabetes in India is around 7.3%, and incidence of exocrine pancreatic insufficiency based on different studies can vary from 36 to even up to 74%, but as low as 5.4% has been reported from Russian studies. The prevalence in type 2 diabetes mellitus varies somewhere between 26 to maybe 35 or 50%. Next slide. Yeah. So the global prevalence of diabetes is 8%. Of the all new diabetics who are diagnosed today, the diagnosis of diabetes of exocrine pancreas is around 8 to 10%. And if you do histomorphology, about 40% of diabetics can show alteration in the exocrine pancreatic morphology. Next slide. What is the connection between the two? How diabetes affects the exocrine pancreas and vice versa. So we'll come to how diabetes affects the exocrine pancreas. Dysregulation of exocrine secretion due to diabetic neuropathy. As we all know that the secretion of different pancreatic enzymes is dependent on an intact neurohormonal mechanism. So basically an intact neuron has to be present for adequate secretion of pancreatic enzymes. In patients who are diabetic with diabetic neuropathy, that particular function might be abnormal. So these are all different hypotheses which we will be discussing. There are some supporting evidences, mostly not in humans, and but will help us understand how the two might be interrelated. There is atrophy of exocrine tissue due to lack of trophic insulin effect. There is local or generalized vascular damage in patients who are diabetic. There might be autoimmune damage to both exocrine and endocrine part of pancreas. A genetic disease might affect the exocrine and endocrine pancreas simultaneously. Next. There is a high incidence of pancreatic disorders in diabetes. This particular study, where they reviewed more than about maybe 1500 patients, they found and they reclassified those diabetic patients into type 1, type 2, and diabetes, which is from exocrine pancreas. They found about 8% of patients were having diabetic of exocrine pancreatic insufficiency. Out of that 8%, 76% were having chronic pancreatitis, 8% were hemochromatosis, 9 were having pancreatic cancer, and 4 were having cystic fibrosis. Next. So, exocrine pancreas does affect the endocrine pancreas as well, which we initially thought are probably two entirely separate organs. The exocrine pancreatic proteases affect the function of the endocrine pancreas. Overexpression of pancreatic proteases increase the number of beta cells. There is integrated blood flow between endocrine and exocrine pancreas. Next. So this is one example where the genetic disease is affecting the exocrine pancreas first, followed by endocrine pancreas. Genetic mutations lead to pancreatic dysfunction, which is followed by diabetes. The typical example is CEL, that is carbohydrate ester lipase, which is a protein present in the exocrine pancreas, but once it is abnormal, can be absorbed by the endocrine beta cells. Subsequently, there is increase in the endoplasmic reticulum stress. It promotes the gene expression of BIP, subsequently beta cell dysfunction and decreased insulin production. So is an example how the exocrine and endocrine pancreas might crosstalk, and a genetic defect predominantly involving the exocrine pancreas can subsequently lead to an endocrine pancreatic damage. Next slide. This is a study which compared the pancreas of patients with type 2 diabetes with or without diabetes. And patients with type 2 diabetes, they basically had larger size of pancreas, more of exocrine fibrosis, more of inter and intralobular fat. There were higher prevalence of pancreatic intraepithelial neoplasia, more acinar to ductal metaplasia, more of small vessel angiopathy, and there was more of greater T cell percentage. Next. So this is the structural and functional relationship. The vascular supply of the exocrine and endocrine pancreas, despite being derived from the same artery, are different. But there is a small portal circulation equivalent happening within the pancreas, which is the insulo-acinar axis. The outflow blood from the islet cell goes into the acinar cell. That means invariably the endocrine secretions are reaching the exocrine pancreas and they are having a trophic effect. So these, not only that, the exocrine pancreas and endocrine pancreas, they are not separated by a capsule. They are actually cohabitating, and thus it's understood that probably there might be a crosstalk happening between the two. Next. So the insufficiencies feed each other. If there is an exocrine pancreatic disorder, which is typically chronic pancreatitis, that leads to increased pancreatic tissue pressure, subsequently ischemic injury, followed by activation of the pancreatic stellate cell, which deposits type 1 collagen, and there is more of fibrotic changes initially in the exocrine and subsequently in the endocrine pancreas as well. The endocrine disorders also affect the exocrine pancreas. Insulin is a trophic factor for the surrounding exocrine tissue. There is an increase in exocrine secretion in response to insulin. There can be autoimmune destruction of both endo and exocrine cells in type 1 diabetics. In one study, they found that there is increased association of body mass index and vascular disease in patients who are having exocrine pancreatic insufficiency. So, a common vascular disease pathogenesis was suggested. As already mentioned, that autonomic neuropathy in diabetics might end up in exocrine pancreatic insufficiency because intact neurons are essential for secretion of pancreatic enzymes. Next, next. So we anyway have been discussing the pathophysiology for the last few slides. The pathophysiology of chronic pancreatitis, be it excess alcohol consumption, metabolic risk factors, environmental or genetic risk factors, or even a gallstone pancreatitis leading to acute or chronic damage, might be a total or partial pancreatectomy, pancreatic agenosis, or different genetic disorders like cystic fibrosis or hemochromatosis. The cell types, all cell types within the islets of Langerhans get affected over time. The insulin secretory capacity is affected. The There is hyperglycemia, there is reduced glucose utilization, and more of hepatic gluconeogenesis. There is also increased, there is also impaired release of incretins, which lead to suboptimal postprandial glucose response. What does it mean is the incretins, that is the GLP and GIP, which are secreted from the intestine, are secreted once they are stimulated by the end products of digestion. In patients who are having exocrine pancreatic insufficiency, the end products of digestions are probably not enough. Hence, the stimulation of incretins are also inadequate, and thus the postprandial insulin secretion, which is mediated by incretin, are also suboptimal, and thus this way it might affect the postprandial glucose management. Next. This is kind of the same thing which is mentioned. Exocrine disorder leads to chronic pancreatitis, increased pancreatic pressure, pancreatic stellate cell activation, finally leading to endocrine pancreatic dysfunction and increase in glucose level. Dysregulation of the incretin system is one of the causes of type 2 diabetes. Mechanism I just already mentioned. Next. So these are the terms which are used. One is a post pancreatitis diabetes mellitus, where after about 3 months, you find after about 3 months of an episode of acute pancreatitis, you find the patient to be diabetic and you did not have prior information. It might be a new onset diabetes after pancreatitis, where the patient was non-diabetic before and within next 3 months of an episode of acute pancreatitis, but subsequently develops diabetes mellitus. And a garden variety of type 2 diabetes was when the patient, even before an episode of pancreatitis, was a diagnosed diabetic. Next. So, in general, these are the varieties of pancreatic injury which can finally lead to a problem in the glucose homeostasis and diabetes. So, it might be post pancreatitis diabetes mellitus, could be post acute pancreatitis, could be a consequence of chronic pancreatitis. It might be pancreatic cancer related diabetes, might be related to cystic fibrosis. Special entities being antecedent diabetes mellitus in pancreatitis and new onset diabetes in pre-symptomatic pancreatic ductal adenocarcinoma. Obviously, stress-induced hyperglycemia, autoimmune diabetes with first recognition after an attack of pancreatitis, diabetes with first recognition during pregnancy after an attack of pancreatitis, MODI, drug-induced diabetes, diabetes after pancreatic surgery, diabetes after blunt pancreatic trauma, diabetes associated with pancreatic agenesis, and diabetes secondary to hereditary hemochromatosis were exclusions. Next. So the factors that suggest exocrine pancreatic insufficiency in diabetes are relatively longer duration of diabetes, changes in the histological structure, which probably you are not going to do day to day, poor diabetes control, laboratory findings of exocrine pancreatic insufficiency, more of micro and macrovascular complications, and pancreatic atrophy or volume changes. If you have symptoms suggestive of exocrine pancreatic insufficiency, like an abdominal discomfort, pain, weight loss, diarrhea, bloating, these also point towards an underlying presence of EPI. Next. So, diabetic patients who may develop EPI requiring treatment are the patients who are in need of insulin, patients who are having uncontrolled diabetes, patients who are having early onset diabetes or a very long term diabetic, the patients who are having relatively more severe disease, and patient who had prior history of pancreatic disease. Next. So, coming to the management part, if you look into the subset of patient who had diabetes of exocrine pancreas, they had more of insulin use, more of neuropathy, more of cerebrovascular disease, more of hypoglycemic spells, more of retinopathy, more of peripheral arterial disease, more of neuropathy, more of coronary artery disease by a factor ranging somewhere between 1.3 times to 1.4 times. Next. And how do you treat this group of patients who are having exocrine pancreatic insufficiency in the background of diabetes? You give them pancreatic enzyme supplement. It improves their steatoria, it improves malabsorption, improves the overall nutritional status, and it has a positive impact on insulin requirement, as will be described in the subsequent slides. But remember, these studies were actually done in patients who were having diabetes of exocrine pancreatic insufficiency. So, this is not equivalent to patients with type 1, type 2 diabetes with or without some features of exocrine pancreatic insufficiency, which are the major group of patients and where the number of studies are very limited. Next. Goals of exocrine pancreatic disorder management would be to control the hyperglycemia, to manage the exocrine deficiency, to manage the nutritional status, and to also address the abdominal symptoms. Next. So these are very general principles for the management of diabetes. You start with oral diabetic, might require insulin later on. The exocrine pancreatic insufficiency happens when more than 90% of the pancreatic parenchyma are affected. The therapy remains in the form of pancreatic enzyme replacement. Insulin might be necessary in patients where the diabetes is secondary to chronic pancreatitis. You have to maintain an optimum nutrition for this group of patients, and they should be having a regular daily exercise habit. Next. Patients who are having diabetes of exocrine pancreas, they require counseling related to pancreatic enzyme replacement therapy. There should be specific attention to the glycemic control. There should be specialized diabetic support because these group of patients have difficult to manage diabetes. We have to start the patient on pancreatic enzyme replacement. There has to be a structured exercise and training program and frequent monitoring of their blood sugars. Next. So this is again a very general description. You do routine diabetes review followed by assessment of the GI symptoms. If there are suggestive GI symptoms, look for clinical features of exocrine pancreatic insufficiency. You rule out the differential diagnosis which I mentioned. Subsequently, once a pancreatic exocrine insufficiency is established, you start the patient on pancreatic enzyme replacement therapy and also ask them to stop smoking and alcohol consumption. Consider a diet which is adequate in fat, and you adjust the dosage of part based on the fat content in their particular meal, and the glycemic management has to be adequate as well. Next. So, if the symptoms are not controlled within 4 to 6 weeks, you have to refer to an expert. Next. Yeah, pancreatic enzyme supplementation. You considerably improves the clinical parameters. This will be described in subsequent slides. It significantly reduces the postprandial sugar levels. One of the mechanism might be through the incretins, which has already been described. Significantly reduces HbA1c, and it definitely reduces the symptoms associated with EPI, improves the overall sense of well-being. Next. Approach would be that the symptoms which do not the symptoms of exocrine pancreatic insufficiency would not manifest till the lipase levels fall to approximately 5 to 10% of the normal. On suspicion, you do a suggestive test. You start the patient on pancreatic enzyme replacement therapy at a lower dose, and then subsequently go up to a higher dose as might be necessary. Next. Overall, the role of pancreatic lipase supplementation are it improves the symptom, it improves the fat and protein absorption, it reduces steatoria, it improves the glycemic control, it improves the postprandial glycemia, improves the incretin hormone response, and overall improves the quality of life. Next. This is basically a pathophysiological mechanism. There is decreased insulin delivery to the draining microvessels because the endocrine part of the pancreas has been damaged. Even if there is some secretion of insulin because of fibrosis, the access of insulin to the blood vessel is lowered. There is obstruction to intrapancreatic insulin circulation because the circulation vessels are damaged, and there is damage to the endocrine tissue and impaired beta cell neogenesis. Next. Yeah, this is one study which describes that compared to those with low pancreatic enzymes, those with high pancreatic enzyme had higher insulin concentration at 9 minutes after carbohydrate ingestion, and the difference was found to be significant. Next. This is one study where patient with diabetes of exocrine pancreas were supplemented with pancreatic enzymes, and once pancreatic enzyme were supplemented, their coefficient for fat and nitrogen absorption improved compared to placebo, which was statistically significant. Next. Pancreatic enzyme increases postprandial response to GLP-1. Supplementation of pancreatic enzyme improves glucose metabolism by restoring the activity of incretins like GLP-1. There is normalization of gastric emptying, normalization of GLP-1 secretion, and increase in glucagon. Pancreatic enzymes trigger incretin secretion. There is higher total GLP-1. There is higher total glucose dependent GIP secretion. There is increased plasma insulin secretion. There is increased plasma C peptide secretion. And there is also increase in total insulin secretion. Next. So these are our snippet of case reports where pancreatic enzyme supplementation was found to be helpful in the management of diabetes. This is a case with the first one is a case of 46-year-old patient with recurrent gallstone pancreatitis who had a high HbA1c. Pancreatic enzyme replacement decreased the HbA1c. The second one was a 57-year-old male with hypertriglyceridemia related pancreatitis and a high HbA1c, where again supplementation with PART was found to be helpful in reducing not only the HbA1c but also the triglyceride level. Cystic fibrosis patient who is 24-year-old is a third case, where again pancreatic enzyme replacement was found to be useful. And the last one is a 36-year-old patient with well-controlled diabetes and known case of MEN1. had recurrent episodes of hypoglycemia when it was found out that the patient had multiple insulinoma. The insulinoma were resected, that's the patient had a partial pancreatectomy, post which the patient's diabetes management worsened, and that was appropriately addressed by pancreatic enzyme replacement therapy. Next. Safety, these enzyme replacements are fairly safe. The adverse events were actually found to be equal between pancreatic supplementation and placebo. The incidence of hypo and hyperglycemia were kind of similar. There are studies which have documented that pot replacement actually decreases the incidence of hypoglycemia in diabetics. Next. So to conclude, exocrine pancreatic insufficiency is common in diabetes. To illustrate on this, the percentages I had already mentioned. For a type 1, it is on the higher side. For type 2, it is on relatively lower side. But the assessments were actually done using fecal elastase 1, which has its own pros and cons. The direct pancreatic enzyme measurements were cumbersome and were not followed in majority. Not just that, this vast majority of patients with diabetes and who had lab-wise exocrine pancreatic insufficiency, very few had a clinical manifestation. Exocrine pancreatic insufficiency can impact the treatment and the outcome of diabetes. Yes, patients with diabetes and exocrine pancreatic insufficiency are a difficult group of patients to manage. Treating exocrine pancreatic insufficiency has several benefits, especially in patients who are having diabetes of exocrine pancreas. Pancreatic enzyme supplementation helps to improve the response to treatment, like I already mentioned. Enzyme supplementation improves insulin response and also incretin response, and enzyme supplementation is safe as well. So these are the take home messages. I think this is the last slide. Thank you for a patient hearing. Can we go to the next slide, please? I think that will be the concluding one. Oh, this is the last one. Okay, thank you. So if
Yes.
any of you have any questions, then I would be happy to answer.
Yes, and now we'll take some queries. I request viewers, if you have any queries, you can post in a comment box. There is one query.
Does
Uh, yeah,
EPI increase insulin level? Now,
yes.
exocrine pancreatic insufficiency will have lesser amount of insulin production. So once you supplement them, their insulin levels are likely to increase and they have better control of their blood sugar. Many diabetic patients are bloating gastroparesis. Whom should we screen for EPI? Yeah, whom should we screen for EPI is a question there is no specific answer to. You should screen everyone where you suspect that the symptoms are because of exocrine pancreatic insufficiency. Because the issue is, whatever studies I showed, whatever slides I presented, the majority of the description is in a group of patients who are having diabetes of exocrine pancreas. That's a minor group. The garden variety of patients that you see every day are basically type 2 diabetics. Now, in type 2 diabetics, it is known that they have exocrine pancreatic insufficiency, but very few of them are actually manifesting the symptom of exocrine pancreatic insufficiency. And how does supplementing pancreatic enzyme in that group of patient help improve in their symptom management and in their control of blood sugar is something which is yet to be researched. In general, for an endocrinologist who are seeing vast number of diabetic patients daily, they do not see very frequent manifestation of EPI, even though if you do a lab investigation, many of them may be having a low fecal elastase 1.
Okay. So, regarding the same question, I have one query from my side. So as you have mentioned that in diabetic patients, it's very common to have EPI also. So, in those cases, what are the symptoms that can be the key factors to identify those kind of patients?
The symptoms are fairly kind of what I already mentioned. They can have bloating sensation, they can have increased stool frequency, they can have steatorrhea in extreme cases. There might be some fullness in the abdomen. They can have pain abdomen as well. Now, if you look at it, these are all very non-specific kind of symptom, other than if somebody is specifically telling steatorrhea. So the problem can always be because of small intestinal bacterial overgrowth, can be because of gastroparesis, can be because of a functional GI disorder coexisting with diabetes. How do you differentiate between them is not an easy answer. So this is a group which requires more research definitely, because this is the majority of diabetics whom we see every day. Diabetes due to pancreatic exocrine insufficiency are relatively lesser in number, and that is where the studies are more abundant.
Yes. So there is a question. Can
Can
we
we
start?
start part in diabetics only on the basis of reports of fecal elastase? Yeah, I told, there is no yes or no. You should start and see the response. Because if you ask what is the basis, why should I start? What is the study supporting this? And what is the expected improvement? These are questions I will not be able to answer. Nobody will be able to answer. All type 2 DM should be screened for exocrine pancreatic function of symptoms. Yeah, if you have symptoms, surely. Prakash Thapa, is there any time period of time of diabetic patient would have the EPI symptoms? Is there any period of time of diabetic patient would have EPI symptoms? So if it is like a type 2 diabetes mellitus, like I showed, if you have a long duration of diabetes, then more likely you will have EPI symptoms. If you have an autoimmune disorder leading to diabetes, like in type 1, you are more likely to experience EPI symptoms early. Is MASLD can lead to EPI? How to diagnose and manage? Can lead to EPI. MASLD can lead to EPI. How to diagnose and diagnosis would be the same. There is no separate method of diagnosis of EPI other than doing the direct and indirect tests or the different other varieties of tests. Can MASLD lead to EPI? Would be an interesting thought. Maybe a part of a metabolic syndrome per se.
Yes. So I think the queries are over. So I request all the viewers, if you have any query, just post it. Otherwise, we'll proceed.
Is there a
Uh,
major indicator and it may cause constipation in what is major indicators? Indicators of what? And it may cause constipation in EPI. Sorry, I could not understand the question.
it is majorly, I think it is about symptoms only that you have already answered about.
Okay, can constipation also be a symptom of exocrine pancreatic insufficiency? No. If that is the question, then no.
So, sir, first of all, thank you for this kind of simple explanation for this very rarely talked topic, and that is important topic as your daily basis, your dealing with those kind of patients, and early diagnosis is very important in those cases. So thank you for talking about this topic. I would request Mr. Supratik to to extend a vote of thanks. I'm just adding him to the stage. Yes, Mr. Supratik.
Yeah, good evening.
Good evening.
Yeah. So thank you, Dr. Kaushik, for giving us a clear-cut explanation regarding the EPI and the management, and an immensely and from the elegance and explanation of everything. So it's from our end. It's I mentioned my deepest sense of appreciation for giving such a time from your busy schedule, and definitely will continue to add more and more such interesting topic in future, and would request you to be a part of our team to help us in this regard. Thank you, sir.
Yeah,
Definitely.
thank you everyone and have a good night. Thank you.
Good
Thank you
night, sir.
so much, sir. Good night. Good night,
Thank you.
everyone. Thank you, viewers.
Thank you.